Hello, I'm Mike Weinblatt from the Brigham Women's Hospital in Boston. And today I'm going to talk about some issues regarding the most common drug we use for rheumatoid arthritis, that being methotrexate. I'm going to spend some time talking about issues regarding dosing of methotrexate, and then also my bias and impressions regarding how to monitor for safe use of the drug. So as everybody knows, methotrexate's been the standard of care for rheumatoid arthritis. It is the number one disease-modifying therapy we use worldwide in the treatment of RA. However, many rheumatologists still today are probably not using the best dose of the drug. And this is a study from 5 years ago that Jim Odell and colleagues performed looking at an insurance data set of over 36,000 patients with RA managed in the United States, starting between 2009 and 2012. And in this study, it was noted that there was only a modest increase in methotrexate use from 15.3 to 15.9 milligrams per week, and 13% of the patients switched to subcutaneous therapy. It's important to note that only 37% of the patients were on a methotrexate dose of greater than 15 milligrams per week prior to starting a biologic. And why is that important? It's important because the therapeutic dose of methotrexate is somewhere between 15 and 25 milligrams per week. So many patients are starting on more expensive therapies before they actually get to a therapeutic dose of methotrexate. Now, how do I use the drug? I generally start patients at a dose between 10 and 20 milligrams per week. In my practice, I'm generally starting at 12.5 milligrams per week. Some of my European colleagues start at 20. I think it really depends upon tolerability issues. It takes at least 4 weeks to begin to note an effect of the drug. And that's due because methotrexate is a monogglutamated compound, and it's polyglutamated to its active form inside the cell. And we need to increase the dose for therapeutic effects. So in my practice, I start at 12.5 milligrams per week. And 4 to 5 weeks later, if the patient's tolerating the medicine, and I will generally increase the dose somewhere to 20 to 25 milligrams per week. There have been several studies that have shown that there's limited value in increasing the methotrexate dose above 25 milligrams per week. Now, as you increase the dose of methotrexate above 17.5 milligrams per week, you lose absorption of the drug and you decrease drug levels. And that's the reason why subcutaneous methotrexate is so effective. And additionally, if you don't want to switch to sub-Q methotrexate, you could split the dose of methotrexate and giving it morning and night 1 day a week. What many of you may not recall is that when we did our first studies with methotrexate in the 1980s, we used split dose methotrexate. We used the dermatology pulse regimen where we dosed 8 a.m., 8 p.m., and 8 a.m. They did it because they thought it would affect skin kinetics, which is not correct. But in essence, they were doing the right thing by splitting the dose to improve absorption. And there have been several small studies that have demonstrated that split dose oral methotrexate achieves the same serum concentrations as sub-Q methotrexate. So once you get patients up to a therapeutic dose, somewhere between 17.5 to 25 milligrams per week, patients will begin to respond within 4 weeks, but a maximum effect may take as long as 12 weeks. In someone who's doing great on the drug, you can begin to slowly reduce the drug over time. I generally maintain the therapeutic dose for 3 to 6 months, and then I gradually reduce the dose by 2.5 milligram increments every month. Now, the American College of Rheumatology has come out with guidelines on the use of methotrexate. This is a committee for which I had the pleasure of being on, for which we had many patients involved. And the patient advocates actually recommended oral therapy over sub-Q therapy initially. Our colleagues in Europe and in Canada, many of them start with sub-Q therapy. And we generally recommend titrating the dose of the drug so that within 4 to 8 weeks, you're on a dose of drug that's above 15 milligrams per week. It's really important that you get the dose up to a therapeutic dose before you add another therapy. If you're increasing the dose, or when you're increasing the dose above 15 milligrams per week, either switch to sub-Q therapy or give it split dose oral. morning and night, 1 day a week. Splitting the dose over a week, such as a Monday-Thursday regimen, historically has been associated with more bone marrow toxicity and liver toxicity. Methotrexate actually works very effectively as a monotherapy, with 30% of patients on methotrexate alone going to low disease activity or remission. And it's important to note that methotrexate increases the efficacy of several of our biologics, including anti-TNF therapy, rituximab, and abatacept. In the case of infliximab and adalimumab, methotrexate increases the drug levels of the monoclonal by 20 to 25%. Now, the question is, what dose of methotrexate do you need to be on to get this effect? And there's been at least 2 studies now with adalimumab in which the methotrexate dose had to be at least 10 milligrams per week to achieve this positive benefit. And with an infliximab, in the only study where this was examined, a dose of methotrexate of 7.5 milligrams per week was sufficient. In a patient who you've placed in low disease activity or remission with methotrexate and a biologic, I generally, over time, try to lower the dose of methotrexate, particularly for tolerability reasons. And the lowest dose of methotrexate I will go down to as I taper is a dose of 10 milligrams per week. Let's talk now and switch gears and talk about monitoring. And what are we most interested in monitoring for? We're most interested in monitoring methotrexate effects on the liver. The only long-term toxicity of methotrexate is liver disease. We know that there's a high incidence of liver toxicity in patients with psoriasis. In a recent study that's come out of the Scandinavian countries, out of Denmark, there was a much higher rate of liver toxicity in psoriasis and psoriatic arthritis as compared to rheumatoid arthritis. And Joel Kremer and I have been studying the effects of methotrexate on the liver for more than 30 years. And we have reported that the risk of serious liver disease at 5 years in a cohort study was less than 1 out of 1,000. I actually think it's much lower than this. In this cohort study, a case-controlled trial in patients who had serious liver disease defined as either biopsy evidence of cirrhosis or in patients with evidence of portal hypertension or ascites or esophageal varices, all of the patients had abnormal liver blood tests a year prior to the seminal event. And by abnormal liver blood tests, we're talking about any level of transaminase above the upper limit of normal or the development of low serum albumin. Based upon this, we have recommended routine monitoring of liver blood tests and considering a fibroscan in patients with persistent abnormalities or recurrent abnormalities in AST and ALT or developing a low serum albumin, and then biopsying when the tests are abnormal. So with monitoring at baseline, and this is based upon a lot of years of work and now in our guidelines, we recommended baseline prior to starting methotrexate, a complete blood count, AST, ALT, and albumin, a serum creatinine, since the drug is 100% cleared by the kidney, and to screen for the presence of hepatitis B and C. And we do TB testing at that time, since many of our patients end up going on a biologic, and considering a chest X-ray in patients with risk for lung disease or with underlying lung disease. We recommend that patients not start methotrexate if they have the AST and ALT above the upper limit of normal. So the liver transamination should be normal prior to starting methotrexate. There have been case reports in patients who had unrecognized hepatitis B or C infection that started methotrexate, and when methotrexate was withdrawn, they developed fulminant hepatitis. So that's one of the reasons we recommend screening for B or C prior to starting the drug. Routine laboratory monitoring is recommended by our professional society every 8 to 12 weeks, and our original recommendation were recommended every 8 weeks. It's now been extended out to 12. There's been a recent paper that was published that suggests that you could basically reduce your monitoring in patients over time. And I absolutely don't agree with this. Methotrexate liver disease occurs with chronic therapy, not in the first 6 months, not in the first 9 months. It's something you've seen after years of treatment. And what you're looking for are subtle changes in liver blood tests above the upper limit of normal. Not one-fold, not two-fold, not three-fold. It's anything above the upper limit of normal of the AST and ALT. And if you see that repetitively over the course of 6 to 12 months, that's when you should consider getting a fibroscan. Sometimes I'll hold their methotrexate, I'll lower their NSAIDs, I'll lower their methotrexate dose, and repeat the blood test. Chronic liver disease should not occur with methotrexate therapy if we appropriately monitor. Now, who's at risk for liver disease from methotrexate? Patients with elevated BMIs are probably the greatest factor in liver toxicity because patients who are morbidly obese have a higher risk of fatty liver, and fatty liver predisposes to hepatic fibrosis. So that's the patients that we should be most cautious about. Insulin-dependent diabetics have a higher risk of NASH, and we need to be concerned about. And patients with significant alcohol consumption are at a greater risk for liver toxicity because of the effects of alcohol on the liver. Those are the three major groups at risk for methotrexate toxicity. Overall, how do we reduce side effects from methotrexate in addition to monitoring? Give patients supplemental folic acid, 1 to 2 milligrams per day to reduce some of the nuisance side effects, such as mouth sores, headaches, diarrhea, and perhaps nausea, as well as fatigue. And in patients who still have side effects despite folic acid, I go to folinic acid or leucovorin, starting with a dose of 5 milligrams given 8 to 12 hours after the methotrexate. If you dose leucovorin within the pharmacological half-life of the drug, you will actually block the effectiveness of methotrexate. And if patients still have the side effect despite 5 milligrams of folinic acid, I increase the dose regularly until I can reduce that side effect. So by careful consideration of our patients, by doing pre-screening prior to starting methotrexate, by monitoring these patients on a regular basis, we can avoid many of the side effects. The other important lab test to monitor is your creatinine, because the drug's 100% cleared by the kidney. So if patients get unrecognized renal disease, and I define that as a GFR of less than 30, they will not clear methotrexate, and over time they're at risk for bone marrow suppression, which could include pancytopenia. So these are some important pearls to think about when you're using methotrexate. And as I noted, methotrexate is the standard of care worldwide in the treatment of RA. Thank you very much.